Hello, this presentation is about learning clinical concepts for predicting risk of progression to severe COVID-19. This work was completed with collaborators at Carnegie Mellon University, Highmark Health Data Science Research and Development, and Allegheny Health Network. I have no relevant disclosures. And after participating in this session, the learning should be able to understand how to define positive anchors for learning clinical concepts, to understand how to utilize these concepts for downstream tasks, such as risk prediction, to apply and analyze survival analysis models to predict risk when patient data is censored, to evaluate models in a backtesting framework and analyze performance over time, and to understand risk factors for severe COVID-19. As COVID-19 becomes endemic, hospitals will continue to need to be prepared for COVID-19 patients. Of particular interest are patients that are likely to progress to severe COVID. So our goal is to predict COVID-19 patients' risk of this progression. Some challenges in this endeavor are that features are often undercoded. That is, the prevalence of some condition in the EHR is much lower than the true prevalence. And this can degrade the accuracy of smaller models that rely on these undercoded features. Additionally, practitioners must face a trade-off between many features, which may help the model be more accurate, versus fewer features that may be more aligned with clinical intuition. Finally, prediction must be done in a constantly evolving environment, where there are new treatments, policies, and disease variants. Our contributions are as follows. We developed two sets of high-performance risk scores, the first of which is an unconstrained risk prediction model built from all available features, and the second of which is a pipeline that first learns a small set of concepts anchored to clinical intuition. We show that learned concepts boost performance over the corresponding features and demonstrate improvements over all available features when evaluated out of sample in subsequent time periods. Our models outperform previous works, and we also release an interactive visualization tool for understanding clinical concepts and their relation to predicted outcomes. We use retrospective observational data collected from January 2020 to January 2022 by a major healthcare provider in southwestern Pennsylvania. The cohort consists of 31,336 individuals testing positive for the first time, denoted as T0. The severe COVID-19 outcome is defined as a composite of mechanical ventilation, ICU admission, or death. And this is a survival outcome that is a time to event defined relative to T0. The features include the location of the test, inpatient versus outpatient, demographics, labs, medications, vaccines, symptoms, and problem history. Here's a summary of the cohort characteristics. Note that there are a substantial number of both inpatients and outpatients, and the most common severe COVID-19 outcome is the ICU admission, followed by death, followed by mechanical ventilation. Our motivation for learning clinical concepts comes from the following. In electronic health records, potential risk factors are often recorded indirectly or unreliably. We often observe the presence of a clinical condition, but not its absence. For example, the presence of a diabetes ICD code likely indicates diabetes, but the reverse is not necessarily true. Models learned automatically often end up using proxies that indirectly encode these important risk factors. For example, the saline IV bolus could indicate inpatient status if this is not directly marked in the electronic health record. And although one could manually map these proxies, it's difficult to be comprehensive in this process. So instead, we use the Anchor and Learn framework from Halpern et al. To learn clinical concepts corresponding to major risk factors. These clinical concepts are then used for downstream risk prediction. In order to learn these clinical concepts, we employ a field of machine learning known as positive and unlabeled learning, or PU learning. For each underlying unobserved binary concept YC of interest, we define an anchor, which is an observed feature that is conditionally independent of all other features conditioned on the concept. That is, the conditional probability of XC given YC equals 1 is equal to the conditional probability when we add all other covariates, XC complement, to the conditioning set. We define a positive anchor as an anchor whose presence almost certainly implies the presence of YC, and an example of this is the diabetes ICD code almost certainly implying the underlying unobserved diabetes concept. Now, given these definitions, let us consider the probability of a positive anchor, xc, given the other observed covariates xc complement. That's in the first line. In the second line, we use the definition of a positive anchor, where xc equals 1 almost certainly implies the presence of the concept yc, that is yc equals 1. The third line, we utilize Bayes' rule in order to break up that probability. In the fourth line, we utilize the definition of an anchor in order to remove xc complement from the conditioning set in the second term. And in the final line, we rearrange the equation to get the final expression, where interestingly, we can note that the probability of being positive versus unlabeled, xc equals 1 versus 0, is actually proportional to the probability of positive versus negative in that underlying concept, yc equals 1 versus 0. And all this is conditioned on your other covariates. Now we're ready to define the PU learning algorithm, that is the anchor and learn framework. For each underlying binary concept yc of interest, we identify some key informative observations, positive anchors, for the concept. Then we learn a positive versus unlabeled logistic regression classifier for the probability of that positive anchor given other covariates. We can then estimate a scaling constant, delta C, by averaging the predictions on all positive examples. Then we can scale predictions from the PU classifier by that estimated scaling constant in order to have estimates of positive versus negative, that is the probability of that underlying concept given the other observed covariates. In order to identify clinical concepts relevant to our prediction task, we sent out a survey to several clinicians in the healthcare provider network. These are the results of the survey on which concepts may be relevant to severe COVID-19 risk prediction. After identifying these concepts, we identified corresponding positive anchors through string matching and clinician recommendation. Then we proceeded with PU learning. After learning those clinical concepts, we focus on the downstream prediction task. In our data, patients are often censored. That is, it's unknown what happened to them past a certain time. Thus, we use survival analysis methods as we are interested in this time to event, where event is either severe COVID-19 or censoring. The particular model we use is the Cox proportional hazards model with L1 regularization, or Lasso-Cox. These are given by the equations to the right. HT, hazard at any point in time, is given by the baseline hazard times e raised to the covariates times the coefficients. And there's this regularization penalty on the L1 norm of the coefficients. And that penalty strength is selected using grid search with fivefold cross-validation and optimizing for discriminative ability as measured by C-index. We learned the Lasso-Cox models from 5 different feature sets. The first is just the raw positive anchors without learning the corresponding clinical concepts. The second is just learning from the learned concepts without all of the other features. The third is the learned concepts plus numerical features, then learned concepts plus all features, and then all features without the learned concepts. For evaluation, we split our data in 2 ways. The motivation here is that as data continues to be generated, hospitals may use new data to update their models over time. And so in the performance over time setup, we retrain models up to the end of each season and then evaluate on subsequent seasons. We use a 70-30 split to create train and test sets for each 3-month period. In the standard setup, we have train and test sets that aggregate across the respective 3-month data sets so that we train the model on the entire study time range. Moving on to results, we start with the learned concepts. Here we show the original prevalence of each concept just based on the anchors, as well as the prevalence after applying the anchor and learn framework. While we cannot evaluate the AUC of the PU classifier due to a lack of negative labels, in green we have the recall of the logistic regression positive versus unlabeled classifier among the original positives. To provide insight into what each PU classifier is learning, as well as how the concepts eventually feed into the final models, we create an interactive Sankey diagram. Moving on to the downstream prediction task, here are the hazard ratios for the all features plus learned concepts, all features, and learned concepts only models. The inpatient feature is the most important one, and we note that in the all features models, there tend to be several medications that are important and could be serving as proxies for other concepts. Here we have the calibration plots for the 1 calibration and decalibration of the learned concepts plus all features model, as well as the learned concepts only model. Here, the learned concepts model appears to be slightly better calibrated than the learned concepts plus all features model. However, when these models are used to stratify patients into high, medium, and low risk strata, both models yield groups with clear separation between their survival curves. Comparing the aggregate performance of our models versus prior work, we note that our models tend to outperform prior work. Finally, while there's some loss of discriminative performance when going from the all features models to the learned concepts only model, when tested under the backtesting framework, this gap seems to close quickly on subsequent time periods, and the learned concepts model eventually even surpasses the performance of the all features model. Thus, models with learned concepts might be more resilient over time than models learned from only all features. If the set of important high-level concepts themselves change over time, however, new concepts may need to be learned accordingly. And in this plot here, the dot represents a simulated deployment date, and the line represents the subsequent performance. We note that whenever learned concepts are present, the model performance seems to be more consistent, whereas when the all features only are used, the model seems to degrade over time. In summary, we learned concepts anchored to clinical intuition, utilized these learned concepts for downstream severe COVID-19 prediction, showed that including all features boosts test performance when evaluated in aggregate. However, when learned concepts are included, they result in more robust performance over time. And we also provide a visualization tool for examining precisely how the concepts are performed. Thank you for your time.